Welcome. My name is Melissa Broats, and I'll be the moderator for today's session. I'm Vice President of Global Marketing and External Affairs at Abbott, where I oversee Abbott's sustainability and community partnership strategies. I'm also president of Abbott's foundation, the Abbott Fund. Our panel today will be talking about two of the greatest challenges of our time, the rise in displaced communities and the growing impact of chronic diseases, also called non-communicable diseases, or NCDs. Just last month, the UN released a report showing the number of displaced people rose to 82 million in 2020, with this number expected to rise to over 100 million in the coming years. Issues like poverty, food insecurity, climate change, conflict, and of course, global pandemics like COVID-19 are increasingly interconnected and driving more people to search for safety and security. While we've all been focused on the COVID-19 pandemic, persistent health problems like diabetes and heart disease continue to take an outsized toll, accounting for nearly 3 out of 4 deaths. And NCDs are also one of the greatest risk factors for severe COVID-19. Many may think that NCDs are primarily a challenge of advanced economies, but our panel will share some numbers to dispel that notion. The intersection of these two crises, chronic disease in displaced populations, has long been an overlooked and underfunded area of need. Our panel is going to shine a spotlight on these issues and talk about some of the challenges and opportunities to address them. But before we dive in, I'd like to welcome each of our guest speakers. First, I'm excited to be joined by Gloria Steele, the Chief Operating Officer of the global humanitarian organization CARE. Most recently, Gloria served as Acting Administrator of the U.S. Agency for International Development earlier this year, and previously as Deputy Assistant Administrator, where she led USAID's Bureau for Asia for the past 4 years. She also previously served as Mission Director for the Philippines, the Pacific Islands, and Mongolia, and as Senior Deputy Assistant Administrator of USAID's Bureau for Global Health. Next, I'd like to introduce Dr. Rachel Nugent, who is Vice President at RTI International, a nonprofit research institute dedicated to addressing the world's most critical problems with science-based solutions. Rachel also serves as director of RTI's Center for Global Non-Communicable Diseases. With more than 30 years of experience in global development, she leads a team focused on cost-effective strategies to prevent and control global NCDs. Finally, I'd like to welcome Dr. Angelo Vega, who is Senior Director of Health, Equity, and Rights at CARE. Dr. Angela has over 20 years of experience in public health program development, management, and monitoring. This includes expertise in disease epidemiology, prevention and care services. Dr. Angela has served in leadership positions across sectors at both government public health departments and nonprofit organizations globally. Welcome to our panelists. We're going to jump right in. Gloria, we know CARE is closely engaged in addressing key needs for displaced communities globally. And in your prior role at USAID, you were involved in these areas as well. Can you kick us off with context on this growing and devastating impact of humanitarian crises around the world? What are some of the impacts in terms of health and other key needs?
Thank you, Melissa. That's a great question to kick off our panel discussion today. Let me start by saying that in 2020, 168 million people needed humanitarian assistance, a number that has significantly grown over the last decade. In this unprecedented year, we launched our largest humanitarian response since the founding of CARE in the aftermath of the Second World War, delivering life-saving assistance to over 92 million individuals across over 100 countries. At the end of 2020, the United Nations estimated that at least 235 million people will need humanitarian assistance in 2021, a very big increase from the previous year. This translates into 1 person for every 33 people worldwide being caught up in a humanitarian crisis, a significant increase from 1 in every 45 people in 2020. In addition to affecting significantly more people, UN data also shows that the average length of humanitarian crisis today has almost doubled over the last 5 years. As of 2019, for example, the average humanitarian crisis lasted for over 9 years. Crisis situations around the world has also become increasingly complex, rendering the delivery of humanitarian aid more challenging because of complicated socioeconomic environments, the diversity of affected groups, inequities, violence, or other societal and geopolitical factors. Today, humanitarian crises are triggered by many more factors than in the past. First factor is conflict. The number of people forcibly displaced because of conflicts has significantly increased over time, exacerbating gender inequalities and gender-based violence. The second factor includes natural disasters and climate change, which have affected 350 million people on average each year and have cost billions of dollars in damages. Third is food insecurity. Between 2015 and 2017, the number of people who experienced crisis-level food insecurity or worse rose from 80 million to 124 million. And then, of course, we have the health crisis, such as Ebola and COVID-19. Speaking of COVID-19, the health and second-order impacts of COVID-19, coupled with the growing impacts of climate change, have increased the number of people in need by 40%, the single largest increase ever recorded in 1 year. This historic level is challenged by a decrease in bilateral aid as donor governments attended to the economic and the social fallout of COVID-19 in their own countries. Indeed, as of December 20th, 2020, the UN reported that the humanitarian response plans and appeals for the past year were funded only at approximately 45% of the need, which is less than half of the appeals. COVID-19 has highlighted some of the worst impacts of humanitarian crisis, such as significant loss of lives, reduced access to healthcare, reduced access to education and other social services, loss of livelihood and shelter, gender-based violence and human trafficking, food insecurity, and a significant downturn in economic growth in every country around the world. Over back to you, Melissa.
Thank you, Gloria. Those numbers are really sobering. Rachel, let's turn to you. Given your expertise in non-communicable diseases, can you talk about the growing devastation of NCDs globally, and what are some of the factors that make NCDs especially challenging for displaced communities?
Yes, thanks, Melissa. And thank you to the Chamber and the Chamber Foundation for this opportunity to speak about this topic. NCDs and low resource settings and fragile settings are my passion. And I think it's so important that people realize the extent of this issue. You mentioned some of the big picture numbers. 3 out of 4 deaths in the world every year are from these NCDs. What are NCDs? Sometimes the terminology we use is inside baseball. It's diabetes, it's heart disease, it's cancer, hypertension. People all over the world are dying from these NCDs. 80% of those deaths are in low resource settings. So the vast majority of deaths are from NCDs. And that's a good story in one way, in that people live longer. They're not dying from childhood diseases as much. And so that's a success. But what's not a success is that so many of these deaths that occur in low resource settings happen prematurely. That is, people often in their 40s, 50s, and 60s that are dying, which as an economist that I am, I often look at things with that economic lens. It means a loss of productivity, a loss of GDP in those countries. So for instance, the chances of dying below age 70 in Haiti are 31% of dying from an NCD compared to the chances of dying from an NCD below age 70, 14% in the US. And all of our attention right now is focused on Haiti. And you can imagine the tragedy of people dying in the prime of their life with such a high probability. So what does that mean in those settings, particularly the settings, the fragile settings of displaced populations? It means impoverishment, It means that people are spending more than twice as much for healthcare on average as people who don't have an NCD in their family. That is, people whose families have just one person living with an NCD are spending much more on their healthcare than people who don't have that within their family. And it often also means lack of continuity of care. So if there is access to care, which is a big question, there's difficulty in getting continuity of care and any management over time. And how that is different from, say, malaria or other infectious diseases is that people need continuity of care. If they're going to be screened and diagnosed and have their diseases managed, so they don't have a sudden heart attack, they need to be able to see a clinician, to see the healthcare worker on a regular basis. So those are some of the differences in people who are displaced or in fragile settings, but experiencing these same diseases that we experience everywhere else in the world. Back over to you, Melissa.
Thank you, Rachel. What you described is something we saw firsthand in our work responding to disasters. The global community has strong models to address immediate needs for food, water, shelter, and emergency care. But this idea of prevention and ongoing care of NCDs in these settings, as we've said, is not and has not been an area of focus. So that's why we reached out to CARE in 2018 to look more closely at this issue and to see how we could collaborate. We knew CARE had unique capabilities in empowering women, mobilizing communities, and strengthening systems. And that matched up well with our own expertise in health and health technology for NCDs. We found out more about CARE's work in the Philippines, particularly in the southern city of Marawi, where armed conflict between government forces and militant groups back in 2017 displaced about 350,000 people from their homes. So Abbott and the Abbott Fund forged a partnership with CARE to find the best way to help, with an eye toward measuring and then sharing results and creating a model that could be scaled elsewhere. In a moment, I'm going to ask Dr. Angela to walk us through this important work. But first, we'd like to share a very brief video, less than a minute, that provides an introduction to this program.
During the Marawi siege, 350,000 people were displaced.
Many health facilities were destroyed, and therefore the health services to the people were disrupted.
In the middle of 2019, CARE and Abbott partnered with our office to address the growing concern for non-communicable diseases.
Nabid no ba malakam ya kalalad namin ni Yugup gito. As I've said last na, so di piki examine, nasakya kumbinsa meron, sakya pa kao maabot, tapos
Now back to our guests. Dr. Angela, can you walk us through the program in the Philippines and the results you're seeing on the ground?
The Philippines is the third most disaster-prone country in the world. It's exposed and extremely vulnerable to natural hazards. At the same time, the island of Mindanao, where Marawi is located, has a long history of protracted and recurring conflict. 8% of adult Filipinos have diabetes. 18% have high blood pressure. 36% are overweight or obese, and 1 in 5 are smokers. In 2017, a 5-month-long conflict between government forces and militant groups forced more than 350,000 residents of Marawi and neighboring towns to flee. 2 years later, 70,000 to 100,000 plus people remain displaced from Marawi and surrounding areas. And together with Abbott, CARE put forward a program. It's actually quite unique, and this is how it works. We work with community health workers who conduct screenings to identify people with non-communicable diseases, that is diabetes and hypertension, and those at risk of developing these chronic diseases. The women would then be identified and trained to lead what are known as non-communicable disease clubs to advance disease prevention and management. The community health workers would then monitor levels of blood pressure, A1Cs, as well as blood sugar regularly, and then refer patients who need medical attention or medication to the facilities that exist. At the same time, the clinical care within the camps where the residents were had expanded access to the individuals who are suffering from diabetes and hypertension. And therefore, we worked to strengthen the local healthcare system to meet the increased demand. And at the same time, we worked with local stakeholders to educate individuals on the prevention and control of non-communicable diseases from the community to the national government level. You asked what have been some of the key results to date. It has been actually quite astounding. We found that there has been an increase in the percentage of hypertensive members with controlled blood pressure. We also found that there has been a decrease in systolic pressure for many of those who are suffering from hypertension. We also found that there's increased number of diabetic members with controlled blood sugar. And then lastly, a decrease in fasting blood glucose levels for some of the members. These results have been actually astounding, and we have been incredibly impressed by them.
Thank you, Dr. Angelo. This model of care empowers women. And Gloria, you mentioned that women are often disproportionately affected by these crises. And it helps position them as leaders of change throughout the process. Gloria, can you talk a bit about the challenges that women are facing and why it's so important to empower them to lead?
Thank you for this question, Melissa. As we all know, as I have said previously, disasters and humanitarian crises disproportionately affect women. For example, when food is short, women and girls eat last and the least. They are also more likely to miss out on education. They are at a much greater risk of sexual violence and human trafficking. They are often the first to lose their jobs and livelihoods. They often have less access to life-saving health services, and they often take on even more responsibilities as caregivers, not just for their own families, but for others too. Most women affected by crisis often have little or no influence over decisions that largely negatively affect them. At the same time, I will note that women should not only be viewed as victims of conflict and instability. Historically, they have shown great strength and resilience and have played a strong role as human rights leaders and active agents in both formal and informal peace building and recovery processes. Thus, in all of CARE's programs, we prioritize supporting women as leaders and advocates in addressing the impacts of development and humanitarian challenges that face them, their households, and their communities. Let me end by talking about CARE's Women Lead in Emergencies Toolkit, which we use to support local women's groups to take the lead in responding to crises that affect them and their communities. This toolkit has been piloted in Colombia, Niger, Mali, the Philippines, Tonga, and in Uganda. And for instance, in Uganda, we have seen that the application of the toolkit increased women's confidence in their negotiation and communication skills by 91%, and it improved their ability to work with other women to achieve their goals from 30 to 92%. Thank you.
Thank you, Gloria. Dr. Angela, can you share some of the other key success factors of the program in the Philippines, such as the roles of community and local officials in driving the program, and how you're addressing the challenges of making this impact that Gloria described more sustainable?
This program is unique for 6 reasons. The first is a focus on non-communicable diseases in emergency settings, which is aligned with recent efforts to prioritize chronic diseases in communities affected by emergencies, an area that is not a priority across the globe. The second reason why the program is unique is that it is among the first of its kind to evaluate the burden of non-communicable diseases in internally displaced populations in Southeast Asia. Again, the growing burden of non-communicable diseases in Southeast Asia makes this program unique. The third is that there is a dearth of data. There's not enough data surrounding the health status of home-based internally displaced persons, and this project will contribute to that evidence base. The fourth reason is that this project includes younger populations. Those are individuals under the age of 40 due to the high burden of non-communicable diseases among Filipinos in this age band. The fifth reason is that this is the first program to employ WHO's STEPS survey in the Philippines, which surveys the population to determine how they're responding to non-communicable disease management. And then lastly, the sixth is that it integrates technology to facilitate health screenings and tracking of program results. Again, technology will be a key factor going forward in terms of management of disease, and this is an area that CARE is leaning into. You asked what are the elements that might make this program sustainable going forward, especially working with national stakeholders, especially the public healthcare system. This program is unique because of 4 elements that work together. The first is the fact that it works with community health workers who live within the internally displaced camps and where the population who is suffering from non-communicable diseases lives, works, plays, and manages their lives. And as Gloria mentioned at the very top, the majority of community health workers are women. So this is an opportunity to empower women and give them greater respect in the community. So in that sense, this model has that key unique element that makes it work very well. The second is that the individuals who have non-communicable diseases are part of what is known as an NCD club. This club fosters unity. It also fosters an ability to have a social group where people who are suffering from non-communicable diseases can get together and manage their disease together. The third unique element is the connection to the formal healthcare system. This is not a standalone project. It is interwoven and interconnected with the existing public healthcare system. And that particular element augurs well for sustainability in the future, so that when this project leaves, it is part of the system that will continue after it ends. And then the fourth and final element that makes this model unique is that it brings advocacy for greater attention to non-communicable diseases in emergency settings. Again, an area that has been ignored in public health globally. Thank you.
Thank you, Dr. Angela. Some good progress there. We've heard a lot about the Philippines, but Rachel, what are you seeing elsewhere in terms of what's working for NCD care? And what do you think it's going to take to make NCD prevention and care a bigger priority in the global community?
Thanks, Melissa. Great questions. Let me just pick up on a few of the points that Dr. Angela made, because they do apply very broadly to the needs of communities and people living with NCDs. One is the issue of data. We really don't have great data about the prevalence and incidence of NCDs, particularly for poor and marginalized people and people who may be IDPs, maybe in fragile settings. So registration, the legal status of people, the ability to be registered and then found and identified, that's really important. And having a STEPS survey among this population is just an incredible advance, because STEPS surveys tell us so much about what the needs of people are and what the health system is able to provide. Once that's in place, once people are found and identified, a few of the things that we've seen that work definitely apply for these populations, but also more broadly. One is task shifting, where possible, from doctors to nurses to community health workers. And much of this care, the screening and ongoing management of a chronic disease can be done by lower cadres of the health system more cheaply and more accessibly. So people will have more access. We can achieve a broader coverage when we're task shifting. It'll take decades to have enough specialists in so many of these settings, and we don't need to do everything with specialists. A second point here is, and we really learned this lesson during COVID, is to try to minimize the burden on the patient. So doing more services in a single visit and providing, for instance, 3 months of medicines instead of 1 month of medicines when someone needs to have a statin or other medicines for their condition. So they don't have to keep coming back. That might raise the per visit cost, but it lowers the overall cost and increases the effective management, effective control of these conditions. And then the third thing I want to mention, again, picking up on one of Dr. Angela's points, is the digital health, the e-health tools. Again, during COVID, there's been so much more experience with digital tools and telehealth. And for NCDs, again, that continuity of care can be done using those tools. And we have an example from Lebanon, for instance, where they have implemented an electronic data system using e-health tools, and they are able to provide health diet counseling, so healthy eating counseling to 77% of the patients compared to 8%. Where you don't have that digital tool for the providers to use to remind them and to serve as a decision support system. So I want to mention one other example of a public-private partnership that is developing this kind of digital tool, and that's the digital compass, the diabetes compass, being developed by the World Diabetes Foundation with support from Novo Nordisk and Novo Nordisk Foundation, where they're going to be customizing for the healthcare workers the digital tools that they can then use as they interact with patients. All of that provides greater access at lower cost and more effective management over time. So I'm really quite excited about those possibilities. Over.
Thank you, Rachel. Really interesting examples of what we can do and additional models of care. So we have just a few minutes left. So we're going to take a lightning round approach. Can each of you share in just a few words one thing that we can all do differently to deliver positive health impact related to NCDs and to scale up what works, especially in context of COVID and the pandemic? Let's start with you, Gloria.
I think that if partner countries are to sustainably achieve their development and humanitarian goals and scale it up, we should focus on enhancing their capacity and commitment to plan and implement local solutions to their development challenges.
Thank you. Rachel.
Yes, very briefly, being able to better integrate chronic care, NCDs, into primary health care. As I mentioned, there are many ways, task shifting and changing the need for specialists and using electronic systems, digital systems. We can integrate our primary health care to cover the overall needs, the full health needs of patients, including NCDs. Thank you.
Thank you. And Dr. Angela.
Echoing Gloria and Rachel as well. Strengthening healthcare systems, especially primary healthcare systems, will be key. A rising tide rises all boats. And as we strengthen health systems to manage COVID-19, we will also strengthen health systems to manage non-communicable diseases. And that includes investing in community health workers, investing in digital health, as well as investing in the primary healthcare infrastructure in marginalized, vulnerable communities.
That was a great summary, Dr. Angela. I'd like to wrap up today by first thanking our panelists. Thank you all for joining us. Hopefully, you all have enjoyed the discussion and found it interesting and illuminating. I know we've just scratched the surface here, but hopefully we've provided some insights on how we can better meet the health needs of our most vulnerable communities. And finally, I'd just like to thank the Chamber for hosting this and having us today. Thank you.